All right. Welcome, everyone. Good evening. Thank you for attending the Tri-State Obesity Society Roots Curriculum Lecture. Today, we have a very special speaker with us, Dr. Devika Umashanker, who is the Medical Director of Obesity Medicine at Hartford Healthcare Medical and Surgical Weight Loss Program. She's board certified in internal medicine and did fellowship in obesity medicine at New York Presbyterian Weill Cornell Medicine. She's an associate professor of clinical medicine at Frank Netter School of Medicine and the program director of the Obesity Medicine Fellowship at Hartford Healthcare. And her primary area of expertise includes post-operative bariatric surgical care and nutrition management, optimizing pre-op weight loss with different treatment modalities prior to surgery, and managing patients medically. So Dr. Umashanker has had several publications and book chapters on the topics of management and treatment of obesity, pharmacotherapy for obesity, and weight stigma and bias. So we're really excited to have you here today, Dr. Umashanker, and I would request everyone in the audience to definitely send in any questions that they have into our chat while you're speaking, and we're going to address them at the end during our Q&A session. So I'll hand it over to you.
Thank you. Thank you, Priya. Thank you to the Tri-State chapter for inviting me to give this lecture on bariatric surgery. So I'm just going to get started. This is my disclosures. The objectives of today's talk will be to review the several bariatric surgical options that are available for eligible patients, to review the role of anti-obesity pharmacotherapy and a very low-calorie diet for preoperative bariatric surgical weight loss patients, and to review post-operative nutrition management and micronutrient management, and discuss the role of anti-obesity medications for post-operative bariatric surgical patients. And before I get started, I wanted to share with the audience today a recent article that was published in the New York Times in regards to one of the New York City hospitals, Bellevue Hospital, and some questionable concerns in terms of their weight loss surgical program, really highlighting some concerns of the quality of care versus the quantity the surgeons were trying to achieve. And hence the ASMBS, which is the major society for bariatric surgery, put a statement out stating how they felt that the article wasn't as comprehensive as it could have been. And really, at the end of the day, bariatric surgery is the gold standard treatment of obesity. And I share this only to highlight how controversial this surgery is on so many levels for many years, even though it's been considered the gold standard of treatment. And so when we think of bariatric surgery, one of the gatekeepers to individuals that get referred to bariatric surgery is primary care. And this study highlighted, what is the knowledge that primary care physicians have? So out of 1,100 surveys that were sent to primary care physicians, 157 responded. And of the 157 that responded, 73% of the patients felt that they had good knowledge. But when they actually tested that knowledge, only 55% of the respondents were able to identify 2 out of the 3 criteria for bariatric surgery, which only further states that there's still so much education that needs to be done within our own colleagues of when to appropriately refer patients to bariatric surgery. And when I do a lecture, I really enjoy sharing with the audience a true case presentation and weave it into the lecture for purposes of interesting clinical scenarios to share. And so I saw this patient, we'll call her patient AJ, who came in for weight management with the recent diagnosis of type 2 diabetes. She was a 40-year-old female with a BMI of 59.3, weighed in at 347 pounds with type 2 diabetes, migraines, anxiety and depression, and PCOS, who wanted to explore non-surgical options. In the past, she was in the workup for bariatric surgery with a different different institution between 2018 and 2019. Her experience, she described, was difficult as she felt like she was being rushed into surgery without the guidance she hoped to obtain. And with her recent diagnosis of type 2 diabetes, she was highly motivated for weight loss. So her goal weight when we were discussing this was 200 pounds and was interested in pharmacotherapy to obtain her goal weight. And so when we did her weight history, her lowest weight as an adult was 340 pounds. She struggled with weight as a child and in her adolescence through her adult years. And her highest weight was about 361 pounds. So we notice right here, even as an adult, she was never lower than 300 pounds, even though her desired weight loss is close to 200. In terms of dietary challenges, she always reported she felt hungry throughout the day, lack of satiety. One of the reasons we ask these questions is we know individuals that respond yes may have lower levels of GLP-1. She had increased levels of cravings and in general described her portions to be large. If you look at her 24-hour food recall, you see that this is quite carbohydrate heavy and less protein heavy. In terms of exercise, she was limited due to bilateral knee pain associated with her weight. And so in terms of her past medical history, as I stated, type 2 diabetes, PCOS, hirsutism, migraines, anxiety and depression, vitamin D deficiency, no surgical history, no known drug allergies, and her medications, she was taking the metformin for type 2 diabetes as well as PCOS, her spironolactone for her hirsutism, ergopant for her acute migraines, and vitamin D as for her deficiency. She is an adopted patient, so we did not have a family history to obtain, and she did not smoke. When reviewing her labs, pertinent positives was her fasting glucose at 167, triglyceride levels above 150, here at 225, and an A1C of 7.3. So some of the questions that comes to mind is her goal weight of 200 pounds, which is a 42.6% total body weight loss achievable with the weight management program utilizing lifestyle modifications with anti-obesity medications? Would her chances be higher if she was to obtain bariatric surgery? Is there an opportunity then to utilize both anti-obesity medications and bariatric surgery to get her to her healthier weight? So I want to focus on the second question in terms of would her chances be higher with obtaining her weight loss goal with bariatric surgery? So as I mentioned before, the bariatric surgery is the gold standard treatment for obesity. And the criteria is a body mass index greater than 40 or more people are eligible. BMI greater than 37, 35 with a weight-related comorbidity, and that weight-related comorbidity can be type 2 diabetes, uncontrolled hypertension, or being on 3 or more antihypertensive medications. Being diagnosed with non-alcoholic fatty liver disease or non-alcoholic steatohepatitis, obstructive sleep apnea, and a BMI greater or equal to 30 with uncontrolled type 2 diabetes. And this is really variable through insurance companies. However, there was a recent change in guidelines that was made in 2022 of last year, published by IFSO and ASMBS, changing the criteria now to eligibility for BMI of 35 or greater with a weight-related comorbidity, BMI of 30 or BMI of 27.5 or greater in an Asian population. I say this because presently insurance companies are not, utilizing this present criteria, but there hopes to be change in terms of the BMI criteria and being eligible for bariatric surgery. So what are the contraindications for bariatric surgery? Severe heart failure, unstable coronary artery disease, decompensated liver disease, portal hypertension, end-stage pulmonary disease, individuals that have drug or alcohol dependency, untreated psychiatric disease such as schizophrenia, schizoaffective disease, individuals with Crohn's disease, are not eligible for Roux-en-Y gastric bypass due to flares in the segment of the intestine that's operated on and complicated post-operative risks that can occur. Barrett's esophagus is contraindicated for a lateral sleeve gastrectomy due to the possibility of it transforming to adenocarcinoma. And so what I hope to do for the next 5 to 7 minutes is to go over the different procedures that are available presently for bariatric surgery, highlighting also the advantages and the disadvantages of each procedure. So going clockwise, we'll be discussing briefly the Roux-en-Y gastric bypass, the vertical sleeve gastrectomy, the biliopancreatic diversion, the lap band, or also called the laparoscopic adjustable gastric banding, and a newer procedure called the single anastomosis duodenal ileal surgery, or also called SADI. So in terms of the laparoscopic gastric band, the procedure is placing a soft silicone ring with an expandable balloon in the center around the top part of the stomach. The band is attached to an injection port under the skin via soft tubing, which allows the adjustment of the band by inflating or deflating the balloon in the band, creating about a two-part stomach with much more smaller top compared to what's on the bottom. And adding saline to the band makes the orifice between the two parts of the stomach smaller. And the intention of this is to do a slower food transit. In terms of advantages, there's lower rate of complications early after the surgery. The band can be removed if needed. It has lower risk for vitamin and mineral deficiencies, and the total body weight loss can be about 15 to 17%, very similar to some of the GLP-1 medications that we are currently seeing. However, what are the disadvantages? So several adjustments and monthly office visits are required during the first year. The risk of the band movement, whether it be slippage or damage to the stomach over time, and a higher rate of conversion. When the conversion does occur, the question then becomes, do you convert to a sleeve or do you convert to a Roux-en-Y gastric bypass? Speaking to my surgical colleagues, the best procedure to convert to is a Roux-en-Y gastric bypass, because the thought process is going from a restrictive procedure of a lap band to then going to a malabsorptive procedure. At this time, many individuals do not do the lap band. Presently, insurances don't even cover the lap band as much due to the complication rates that have seen historically. If the patients are interested in doing the lap band, the preferred BMI is between the class 1 obesity classification between a BMI of 30 to 34.9. Speaking to my colleagues, any classification above that, patients just don't do well with the lap band. In terms of the lateral sleeve gastrectomy, it's removal of 80% of the proximal portion of the stomach, where your stomach looks like a banana. The ghrelin, which is located mostly in the proximal stomach, in which is how the surgery has an effect on the metabolism. How so? By removing the ghrelin, we are decreasing hunger and increasing satiety levels. Advantages of this surgery is technically it's simple and shorter in time. How much is the time? Anywhere between 45 minutes to an hour and a half. May be performed as the first step for patients with severe obesity that we define to be a BMI greater than 50, and bridge to gastric bypass or SADI as procedures. It's effective weight loss and improvement of obesity related conditions, and total body weight loss can be seen anywhere between 20 to 25%. The disadvantages of this surgical procedure is that it is non-reversible. It may worsen or cause new onset of reflux and heartburn, which we have seen frequently in our clinic, and it has a less impact on the metabolism compared to the bypass procedure. However, this is the procedure that is most commonly performed across the country at this time. The Roux-en-Y gastric bypass, the procedure is when the stomach is divided into a smaller top portion containing about 15 to 20 cc's. The larger part of the stomach is bypassed and no longer stores or digests food. The small intestine is divided and connected to new stomach pouch to allow food to pass. And the small bowel segment, which empties the bypass or larger stomach, is then connected to the small bowel approximately 3 to 4 feet downstream, resulting in a bowel connection resembling the shape of the letter Y. The advantages of this procedure is the effectiveness for remission of obesity-associated conditions, specifically type 2 diabetes. We have a total body weight loss anywhere between 30 to 35%. The disadvantages of this procedure is that it increases vitamin and mineral deficiencies more than sleeve gastrectomy or gastric banding. What we know is with the duodenum being bypassed, there's poor absorption of iron and calcium, leading to iron deficiency anemia. There's higher risks for small bowel complications and obstruction and developing ulcers, especially if individuals go back to smoking or start using NSAIDs. And as we all know, there is a concern of developing dumping syndrome. So the biliopancreatic diversion with duodenal switch is not commonly performed. I will share with everyone here today, it is not performed at Hartford Healthcare Medical Group. But the procedure is that it is two parts. One is it's a sleeve gastrectomy. The pylorus stays intact rather than being bypassed. However, the small intestine is divided at the duodenum and connected to the ileum. The jejunum is bypassed. And so the food is rerouted to the ileum, bypassing the jejunum, and the jejunum joins the ileum, forming a connection in the shape of a Y. And so what are the advantages? It's most effective procedure for the treatment of type 2 diabetes. You get a total body weight loss greater than 35%. However, the disadvantages is that it has a higher complication rate with increased length of stay in the hospital and higher malabsorption and greater possibility of vitamin and micronutrient deficiencies, leading to metabolic bone disease and anemia, and the concern of having chronic diarrhea. I want to briefly talk about SADI-S. This procedure is also part sleeve gastrectomy, where first part of the duodenum is divided after the stomach. The intestine is attached to the duodenal stump about 200 to 300 centimeters from the colon. The advantage is that, it's a new procedure, but that can be considered a disadvantage as well. It's highly effective for long-term weight loss and remission of type 2 diabetes. It's simpler and faster to perform comparatively to gastric bypass or BPDDS. But the disadvantages is vitamins and minerals are not absorbed as well as in the sleeve gastrectomy or gastric band. And it's a neuro operation with only short-term outcome data that's available. I just wanted to briefly say that, they did a study looking at SADI's 1-year outcome, and the purpose of the study was to evaluate weight loss, comorbidity resolution, and the 1-year nutritional outcome of the SADI procedure. They looked at patients between October 2014 to October 2017, 120 patients, of which 65 of them had type 2 diabetes. They were enrolled at 6 different sites and were followed post-procedure for 12 months. At 12 months, what they found was individuals had a significant weight loss up to 46.8 0.8 percentage of weight loss. The patients overall had really good resolution of their type 2 diabetes, and they saw a reduction in hyperlipidemia, obstructive sleep apnea, and hypertension. When you compare the traditional duodenal switch with SADI, one of the studies wanted to look to see what was the retrospective data on that. And they looked at a sample size of 30 individuals in each group. And what they found was individuals in the duodenal switch procedure arm had better weight loss at 6 years than SADI-S. The long-term difference between the two groups was approximately 15 to 20 pounds without an impact on comorbidity resolution. So after sharing this with all of you, which bariatric procedure should be offered to our patient? And so in general, when bariatric procedures are decided upon, it's really based on individualized goals of therapy. What's the patient's weight loss target? Specific improvements they are looking for in terms of their obesity-related comorbidities or complications. And, what is the available local regional expertise that can help support them even after the procedure. And it also comes down to patient preferences. So with this patient with a significant past medical history of type 2 diabetes and a BMI of 59.3, why surgical weight loss in patients with this medical history? And what we know is in terms of diabetes and bariatric surgery, we know that postprandial GLP-1 levels, PYY, oxynomodulin are increased, leading to improved beta cell glucose sensitivity and lower postprandial blood glucose. Why do some procedures affect glycemic control more than others? There's two type of hypothesis that we think about. One is the hindgut hypothesis that states that bypassing the proximal small bowel causes rapid transit of nutrients into the distal bowel, increasing secretion of gut hormones such as GLP-1 and PYY. And foregut hypothesis is the exclusion of nutrients from the duodenum and proximal jejunum, decreasing secretion as of yet an unidentified signal that increases insulin resistance. And what we also know is that there can become changes in the microbiome. There is an elevation in the pH of the stomach, causing an increased level of Firmicutes and decreased levels of Bacteroides. More rearrangement of the GI tract causes small reproducible improvement in long-term and glycemic control compared to patients undergoing less drastic procedures. So I just wanted to share with everyone the study that was published by Dr. Schauer, who's well known in the bariatric and medical community for bariatric surgery, in terms of the clinical outcomes of metabolic surgery and the efficacy of glycemic control, weight loss, and remission of diabetes. And what we see here is 4 different studies that were looked at and evaluating the changes in hemoglobin A1C. And what we notice is by far, the surgical procedures always seem to provide greater reduction in A1C comparatively to medical therapy. Gastric bypass being second to biliopancreatic diversion. And so when we look at remission at 5 years in the study, what we also see is the surgical interventions providing more remission comparatively to comparatively to medical treatment. And so for this patient, after discussion of total body weight loss goals with anti-obesity pharmacotherapy, resolution of weight-related comorbidities, patient was referred to surgical weight loss. She was started on her preoperative bariatric surgery process, and it was deemed that she would be appropriate for Roux-en-Y gastric bypass. And I just wanted to share with everyone today, what does that pre-procedure evaluation look like? So initially, there's a consult with the bariatric surgeon. At the consult, labs are ordered. They want to see what baseline CBC to evaluate for any anemia, a CMP panel, a lipid profile, A1C, and a TSH. A nutritional panel is also obtained, including iron studies, B12, folic acid, and vitamin D. And so what we do normally is based off of the clinical practice guidelines for pre-op nutrition, we have our own checklist that we want patients to go by. There's a lifestyle medicine evaluation where they may get cardiovascular fitness evaluation, strength training evaluation to properly guide them even through the pre-op and post-op phase. Sleep hygiene is also highly recommended. A clinical nutrition evaluation is done by the registered dietitian. A cardiopulmonary evaluation with sleep a specialist is done. Also, an evaluation with cardiology is also done if appropriate. Pregnancy and smoking counseling is provided, and patients are assessed for individual psychological support and counseling. If patients are deemed that they don't have proper support, they may not be approved for the surgical procedure. And we continue to encourage efforts for preoperative weight loss. And in my later slides, I'll talk about the impact of preoperative weight loss on postoperative weight loss. But I just wanted to focus on pregnancy and smoking counseling. In terms of smoking and bariatric surgery, there's a lot of data that shares that individuals that continue to smoke after bariatric surgery tend to be at higher risk for ulceration. And so this study looked to see, should recent smoking be a contraindication for sleeve gastrectomy? They evaluated a sample size of 33,000 individuals approximately, of which 30,418 were going for the sleeve gastrectomy. 3,296 patients had said that they had smoked within a year before surgery. And what they found was individuals that smoked closer to the surgical date had higher unplanned intubation, longer length of stays in the hospital, and higher readmission rate and unplanned readmissions. And so another study looked to see what are the changes in smoking behavior before and after a gastric bypass. So this was a prospective study that looked at individuals who had a gastric bypass between 2006 and 2009 and followed to 2015, of which what they saw was 45.2% of individuals had pre-surgery history of smoking. And what they found is 67% of those individuals reverted back to surgery. So in our clinic, we highly encourage patients to, quit smoking just because of the complication risks that can involve based on this type of surgery that they had. But I believe many of them stick to smoking, especially if they start seeing some weight gain due to the suppressive appetite qualities that they have with, or they find to think in smoking. So in terms of pregnancy and bariatric surgery, this is a big topic in our team because many times we recommend individuals to not get pregnant till 12 to 18 months after surgery. And as many as people already may know on this call, individuals after surgery, their levels of fertility rate increases significantly. But the problem is if you were to get pregnant immediately after surgery, one thought is that you may have not created your new set point, as pregnancy can also alter that. And so another concern that happens is within the pregnancy period of malnutrition could lead to adverse outcomes such as low birth weight or malformation on the baby. And several studies have compared outcomes between pregnancy conceived early, less than 12 months after surgery, and after 12 or 18 months after surgery, and there was no significant differences in perinatal outcomes between the two time periods. The largest of these studies determined that hypertension, diabetes, or bariatric complications were not that different between the two groups. And so going here, I just also wanted to focus on the psychological aspect of bariatric surgery. And so initially and overall, bariatric surgery has a positive overall impact on weight and obesity related comorbidities, and positive short-term impact on mental health and psychosocial functioning. Some concerns after bariatric surgery is maladaptive eating, substance use disorders, suicide, and a lack of social support that can impact this. Certain sociodemographic factors, such as young age or severity of obesity, can have distinctive psychosocial concerns. And if any of this above has been identified during your assessment, most often bariatric surgery is placed on hold. I wanted to also share with the audience today, the effect of weight stigma and internal weight bias on bariatric surgery. So, what is weight stigma? It refers to the discriminatory acts and ideologies targeted towards individuals because of their weight and size. Internalized weight bias is self-directed weight stigma, the belief that negative stereotypes about weight applies to themselves. And what we have seen is individuals that have scored high in weight stigma and internalized weight bias post-operatively have less weight loss than their counterparts who did not score high on these questionnaires preoperatively. And so what is, the effects of preoperative weight loss? Is there any benefit? And so multiple studies have been published on this, and I can share with everyone today, presently there is no mandate that requires individuals to lose weight prior to surgery by insurance or many medical departments. What we do know is that the results show that some studies show that there can be some increased postoperative weight loss, and some studies show that it has no effect. But what we do have seen is in a paper that was published by JAMA that individuals that had preoperative body weight loss had a decrease in 30-day mortality. And so that's something to be considered. We also know with preoperative weight loss, we reduce the size of the liver, we reduce central adiposity, improving surgical techniques, making it a safer procedure overall. So I wanted to share with everyone the lifeline of what happened with the patient I was taking care of. So when this patient first started our program, we placed her on semaglutide. She discontinued metformin because she felt like with the side effect of diarrhea, it was not sustainable for her to be on that medication for long term. At the time of initiation of semaglutide 0.25, her weight was 338 pounds with a BMI of 58.53. When she came in at her next visit, there was a weight gain that we saw with the patient. She felt that the semaglutide did not decrease her appetite, and she was pretty discouraged with the weight gain that she achieved. So in our program, we do a very low-calorie diet program, which is a 12-week program that we start patients preoperatively, and we started her on 0.5 milligrams of semaglutide with the instructions to increase to 1 milligrams. And so when we talk about very low calorie diets for patients with obesity, what we have seen is these patients go through a process called nutritional ketosis. And what we have seen is with this rapid weight loss patients achieve, there's a level of positive reinforcement that occurs that continues encouraging patients to do their lifestyle modifications, engage in physical activity levels to help further promote weight loss. Overall, some concerns with these type of very low calorie diet programs, which is about an 800 calorie program, is the safety and the efficacy of these programs. And I can share with you, doing this very low calorie diet program in our present institution, we haven't seen any significant concerns in safety. or in challenges of patients being on the program for long term. In one of our own retrospective studies that we saw in individuals engaged in a 12-week program with a BMI greater than 50 on an anti-obesity medications, interestingly enough, patients on an anti-obesity medication didn't lose more weight than individuals not on an anti-obesity medication in a VLCD program. However, what we did find was those individuals on an anti-obesity medication were able to complete the program. So that just goes to show, in how many different ways we can utilize anti-obesity medications in different treatment nutritional modalities that we have available. And so in general, what are the indications for a very low calorie diet program? Usually anyone with a BMI greater than 30 or a BMI greater than 27 with a weight-related comorbidity. Those are the general indications. However, in our program, we try to enforce that it be really for people with a BMI greater than 50. Contraindications of this, nutritional program are individuals who have heart failure, coronary artery disease, individuals that are pregnant, individuals that have untreated psychiatric disease. The option of using it in individuals with chronic kidney disease. There is a paper that's published that shows how you can utilize a VLCD even on patients with chronic kidney disease on dialysis. And there is literature available that guides us on how to use this very low calorie diet in patients that may have liver disease as well. And so I wanted to share with everyone with the VLCD program, patient on an anti-obesity medication lost about 15.85% of her total body weight loss, actually very comparatively to a lap band within itself. And 1 month post follow-up with our patients, we definitely review our dietary and nutrition recommendations, review post-operative complications, and then the question becomes, when do you restart anti-obesity pharmacotherapy in patients with bariatric surgery? So I just first want to go over the dietary and nutritional recommendations. There are several recommendations that are available, and I've just kind of outlined it in bullet form on this slide. I'm just going to go over just some basic dietary recommendations that we have for our patients for bariatric surgery. One is we recommend fluids for women 48 ounces per day, men 64 ounces per day at least. Your protein intake for women is about 46 grams and for men 56 grams. Your protein needs are about 10 to 35% of your daily caloric intake. For weight maintenance, it's 0.8 to 1.2 grams per kilogram body weight per day. And if you're having active weight loss, about 1.2 grams or to kilogram body weight. And if depending on the procedure of your surgery, you may need higher requirements of protein. For patients in terms of carbohydrates, early post-op, we recommend 50 grams a day. And as people go further into their post-op time frame, it can increase to about 130 grams per day. Your fat composition of a dietary intake should be about 20 to 35% of your daily caloric intake. In terms of bariatric surgery and nutrition, these are the different vitamins that we look into and follow up with patients. I will share with you one of the most important vitamins that we're all aware of that we should be following very carefully is thiamine levels. It can cause Wernicke encephalopathy and can be quite dangerous for the patient and the family in itself. And so here is the dosages of the medications for the different vitamins and micronutrients. I don't want to read it off. I'm just going to share this slide. And if anybody wants this, please let me know and I'd be happy to send it over to you. In terms of that 1 month post-operative follow-up, we talk about, I mentioned the dietary and nutritional recommendations. Now I want to talk about post-operative complications that can occur. What we know is in this article that was published in the New England Journal of Medicine, when they looked at life expectancy after bariatric patients in the Swedish obese subject study, the listed death and complications during the first 90 days after bariatric surgery varied. It could be PE, thromboembolism, an anastomotic leak, ileus, wound dehiscence can occur. Another element I wanted to share with you is that if any of this was to happen, patients are always highly monitored the first 30 days to 60 days after post-op and have all access to our team to make sure that we properly guide them if they were to experience any symptoms that could lead to any of these concerns like a PE. So when do you start anti-obesity pharmacotherapy in patients with bariatric surgery? I can share with you that the results usually are very variable. Some studies have shared that the best time to start the best time to start anti-obesity medications is post-operatively when patients have had weight regain. There was a paper that was published by Dr. Aroni and Dr. Shukla that suggested that it should potentially be considered to start at weight plateau. And I just wanted to highlight some studies that have shown what occurs when you start anti-obesity medications preoperatively and then restarted post-operatively 48 weeks after the surgery. What does those results look like? And that was highlighted in Dr. Ard's publication in 2019 in SWORD. And what his study looked at is utilizing phentermine and topiramate before individuals had sleeve gastrectomy and utilizing it after sleeve gastrectomy and comparing it to an arm who had no anti-obesity medications. And this was in a population with BMI greater than 50. And what I wanted to share with everyone here today is, interestingly, even when you start medications before surgery for people above a BMI greater than 50 and after the surgery, even though that arm did better than the arm with just sleeve gastrectomy, you notice that those individuals never get to a BMI less than 30. And so that's just an interesting point I wanted to share with everyone. When individuals with higher BMIs are interested in bariatric surgery and share that they want to have a BMI of 24, these type of studies allow us as physicians to properly counsel them and to level set expectations, also noting that we have also limited literature and research in this area. So going back to my own patient, she had a 2-month follow-up after surgery. And at that time, her BMI was 42.7 with a weight of 265 pounds. And we restarted her on semaglutide at 0.25. And this patient has done beautifully over time. We have gone as high as 1 milligram on the semaglutide, and patient has achieved a weight of 218 pounds compared to where she started at 338. And with the treatment of medical weight loss and surgical weight loss, patient was able to achieve a 37.7% total body weight loss, which is quite significant. So in terms of clinical pearls and takeaways from this presentation, I was hoping, individuals now have a better understanding for the criteria for bariatric surgery, even though there's been some new updates on that criteria, which patient is appropriate for bariatric surgery and not suitable based on past medical history, and when and how to use anti-obesity medications pre and post bariatric surgery. And I'd be happy to take any questions now.
Thank you so much for such a wonderful lecture. It was such a great walkthrough from the medical side to the surgical side, and then closing the loop back to the medical side. Truly beautifully done. And we do have some questions, and I'm just going to read through them. So the first question we have is, which surgery carries the most risk to develop a postprandial hypoglycemia? And is this something to worry about if a patient has type 1 diabetes or type 2 diabetes? And I think they mean on insulin.
Yep. I would say the surgery that we would be most concerned about is Roux-en-Y gastric bypass. Working with our patients, whether it be type 1 diabetes or type 2 diabetes, we work very closely with our endocrinology colleagues, with those individuals who have that diagnosis, having a Roux-en-Y gastric bypass. So it's a collaborative approach when treating these patients.
Great. And then the next question we have is, when do you discuss surgery with a patient with the option of new medications that have come out?
Okay, when do you discuss these medications? So for patients for preoperative surgery, I usually discuss these medications if they have a BMI greater than 50. Which medication we use, it was really variable by insurance coverage. I'll be very honest with you, with in the state of Connecticut where I practice, there's shortage of medications of semaglutide, of tirzepatide at different dosages. So I can share with you, it's a very interesting time right now in medicine, and I'm sure many of you are seeing this, where patients are coming and asking you, right? They're like, can I please get Ozempic? Like, what in our years of practice and in residency, no one comes and asks us, can I get hydrochlorothiazide, right? It's like so different right now. But I actually just go back to phentermine and topiramate. It is one of my favorite combinations, and it works. It really does. As long as people are able to tolerate the side effects of specifically topiramate, that is usually my go-to. And when they're coming to me for preoperative weight loss, I start that medication if they're open to it at the day of consult.
Is there any reservation with patients who may have a history of sleep apnea when you're looking into medications such as phentermine, topiramate as combination, or phentermine alone?
Yeah, I don't have any reservations with that when I start that medication. I usually feel quite comfortable utilizing it.
And then the other question we have is, do you find that there's any difference in the utilization of GLP-1s in patients post-bariatric surgery? Or is there any difference that you need to make in the way you are counseling patients?
Yeah, so I can share with you with utilizing GLP-1s post-operatively. So I've been here at Hartford Healthcare for 7 years. I used to use liraglutide and dilaglutide as my medications to go to. When patients are now presently interested in using semaglutide, I do see a difference. I think there was actually a poster on actually a paper that was published in the obesity journal by Dr. Almendez out of UT, comparing the different GLP-1s, and semaglutide was superior in terms of post-operative weight loss for individuals that had weight recurrence. And I do see that in clinical in real time as well.
Okay. Then we have a clinical question. Looks like it says, oftentimes we have patients coming in mentioning that they have bariatric surgery, and they often don't remember what surgery they had. Is it possible to find out what surgery they had by sending them back to bariatric surgery? And how far out do we have to screen them for nutritional deficiencies? And should we send them back to bariatric surgery?
Yes. So I would share this with you. You can absolutely either send them back to bariatric surgery, or I usually just try to ask if they remember the name of the surgeon, and then we kind of do the behind the scenes calling and getting the records. Because sometimes when you send them back to surgery, they just get kind of lost in the shuffle. In terms of how long do you check for nutritional or micronutrient deficiencies, you do it every year. That is the recommendation. And I'm sorry, what was the third question again?
It looks like here is how far out should they be screened for nutritional deficiencies, and should we send them back to bariatric surgery to
Yes.
be depleted?
Yeah, I would say it depends on your team. We manage it here mostly, especially if we're taking care of the medication arm. Patients just would rather see one clinician rather than going to two different visits. Um, I don't feel strongly either way sending it back. I'm sure every system runs it differently here. Because we're so collaborative and we see the same patients, we kind of just absorb that as well.
Okay. And then there's one more question here. It says, do you find that it's difficult for patients who had bariatric surgery to obtain the amount of recommended protein that they're supposed to be getting?
Yes. The answer is yes. Some of the patients struggle. When we talk about amount of protein, 16 to 80 grams, they struggle for the first couple of months, even up to a year. It gets better over time. And then you see it change a little bit more in terms of and more of an increase of a carbohydrate intake and decrease of protein, which is why I think continuous follow-up is so important with our bariatric patients. Here at Hartford, the follow-up after 1 year is only 60%. So 40%, we don't even know what happens to these patients, and they usually come back with weight recurrence. And I always share with them, especially patients that I've worked with preoperatively, the importance of every year follow-up, vitamin follow-up, the whole gamut of blood work that needs to be done. And just for us to be on top of any sort of weight recurrence that occurs, because the most challenging part is when patients lose the weight, get lost to follow-up, and come back when they've regained all the weight back.
Okay. And just personally, we talk a lot about updates in, the medical field when it comes to obesity medicine. Anything that you've heard from your colleagues, maybe on the surgical end, that's coming up?
In terms of, so I can share with you, there's a big push for the new IFSO and ASMBS guidelines to be incorporated and absorbed by the insurance companies. As I shared with you, it's a significant difference right now in terms of what the criteria presently is with BMI greater than 40 and what the proposed is of BMI greater than 35. What I think is going to be really interesting is to see how GLP-1 medications impacts that referral process for people with lower BMI. So, only time will tell.
Thank you so much, Dr. Umashanker. This was a great lecture. It was very, very
Thank
informative,
you.
and I'm so excited to share this with the rest of our fellow colleagues and post this on our YouTube channel. So for the rest of the audience, thank you so much for coming out. Stay tuned with Tri-State Obesity Society. You can visit our website, join for membership, and follow our YouTube channel. Thank you so much, everyone. Good
Thank
night.
you, everyone. Have a good night. Bye-bye.